This chapter introduces the muscular system, which functions as the primary engine of human movement and physical stability. While bones provide structural support, it is skeletal muscle contraction that allows individuals to sit, stand, walk, and perform daily activities. From a physiological perspective, skeletal muscle is composed of specialized fibers capable of generating force through the interaction of actin and myosin filaments. This process, known as the sliding filament mechanism, depends on adequate levels of calcium ions and adenosine triphosphate to sustain contraction. Clinically, impairment of muscular function may result in weakness, fatigue, impaired mobility, and increased risk of falls. These changes directly influence patient safety, rehabilitation outcomes, and independence in activities of daily living. For NCLEX style application, learners must recognize that muscular dysfunction often presents as difficulty with transfers, ambulation, and posture control. At that early identification of these deficits, it's essentially preventing injury and promoting recovery. Throughout this chapter, emphasis will be placed on understanding muscle tissue organization, contraction physiology, and major function muscle groups, while integrating targeted memorization of high yield structures necessary for safe and effective nursing practice. The muscular system performs several essential functions that support both movement and physiological stability. Through coordinated skeletal muscle contraction, the body is able to generate controlled movement required for walking, transferring, and performing activities of daily living. In addition to movement, muscles play a critical role in maintaining posture and balance through continuous low-level activity known as muscle tone. This baseline tension helps stabilize joints and supports proper body alignment, particularly during standing and sitting. From a physiological standpoint, muscle activity also contributes to heat production, a process referred to as thermogenesis, which assists in regulating body temperature. During sustained activity, increased muscle metabolism helps prevent excessive heat loss. Muscles also support circulatory and respiratory function by promoting venous return from the lower extremities and by assisting with effective chest wall expansion during breathing. Clinically, impairment of muscular function may result in weakness, instability, reduced endurance, and increased fall risk. These changes directly affect patient safety, mobility, and independence. For NCLEX style application, learners should recognize that difficulty with ambulation, transfers, or posture control often reflects underlying muscular dysfunction and requires timely assessment and appropriate intervention. The human body contains three primary types of muscle tissues: skeletal muscle, cardiac muscle, and smooth muscle tissues. Each type is structurally specialized to perform distinct physiological functions. Skeletal muscle is responsible for voluntary movement and is attached to bones by tendons. These muscles allow individuals to walk, lift objects, and perform purposeful activities. Skeletal muscle fibers are characterized by visible striations and multiple nuclei, reflecting their high energy demands. Cardiac muscle is found exclusively in the heart and functions involuntarily to maintain continuous blood circulation. These fibers are branched and connected by intercalated discs, which allow rapid electrical communication and synchronized contraction. Smooth muscle is located within the walls of internal organs and blood vessels. It functions involuntarily to regulate processes such as digestion, urination, and vascular tone. Unlike skeletal and cardiac muscle, smooth muscle lacks visible striations and contracts in a slow, sustained manner. From a clinical perspective, dysfunction in any muscle tissue type may significantly affect patient health. Skeletal muscle weakness may impair mobility, cardiac muscle abnormalities may reduce cardiac output, and smooth muscle dysfunction may disrupt normal organ function. For NCLEX style application, learners should recognize that identifying the affected muscle tissue type helps guide clinical assessment, monitoring, and appropriate intervention. Skeletal muscle is organized in a highly structured, hierarchical manner that allows it to generate force efficiently and respond to neurological signals with precision. This organization begins at the level of the entire muscle organ and extends down to microscopic contractile units. For each muscle is composed of bundles known as fascicles, which contain individual muscle fibers, also referred to as muscle cells. These fibers are elongated, multinucleated cells specialized for contraction. Within each muscle fiber are numerous myofibrils, which are long, thread-like structures responsible for generating tension. Myofibrils are composed of repeating functional units called sarcomeres, which serve as the basic units of muscle contraction. Surrounding and supporting these structural components are layers of connective tissue. The epimysium encloses the entire muscle. The perimysium surrounds each fascicle, and the endomysium wraps individual muscle fibers. These layers provide structural support and serve as pathways for blood vessels and nerves. From a clinical perspective, damage to muscle fibers or their connective tissue coverings may result in weakness, reduced coordination, and delayed healing. Impaired circulation within these layers may further compromise muscle performance and recovery. For NCLEX style application, learners should recognize that muscle injuries, strains, and surgical trauma often disrupt this organizational structure, leading to impaired force generation and functional limitations that require targeted assessment and intervention. Skeletal muscle contraction occurs at the level of the sarcomere, which represents the fundamental structural and functional unit of a muscle fiber. Each sarcomere extends from one Z-line to the next and contains precisely arranged protein filaments that enable force generation. Within the sarcomere, actin filaments, also known as thin filaments, extend inward from each Z-line, while myosin filaments or thick filaments occupy the central region. The orderly overlap between these filaments forms distinct bands that are visible under microscopy. The A band represents the region where myosin is present, including areas of overlap with actin. In contrast, the I band contains only actin filaments, while the H zone represents the central region containing only myosin. Several regulatory and structural proteins maintain proper filament alignment and control contraction. Titin stabilizes the position of myosin within the sarcomere, while troponin and tropomyosin regulate access to binding sites of actin. This protein ensures that contraction occurs only when appropriate stimulation is present. From a clinical perspective, damage to sarcomere components may result in weak contraction, rapid fatigue, and reduced muscle performance. Abnormalities in calcium regulation or structural proteins may contribute to various muscular disorders. For NCLEX-style application, learners should recognize that effective muscle contraction depends on intact sarcomere structure and proper regulatory control. Disruption at this microscopic level often manifests clinically as decreased strength, impaired mobility, and reduced activity tolerance. Skeletal muscle contraction occurs through a coordinated process known as the sliding filament mechanism, in which thin and thick filaments slide past one another to shorten the sarcomere and generate force. This process begins when a motor neuron releases acetylcholine at the neuromuscular junction, triggering an electrical impulse along the muscle fiber membranes. This impulse stimulates the sarcoplasmic reticulum to release calcium ions into the cytoplasm. Calcium ions bind to troponin, causing tropomyosin to shift away from the binding sites on actin. This exposes specific regions on the thin filaments, allowing interaction with myosin heads. Once the binding sites are exposed, myosin heads attach to actin, forming structures known as cross bridges. Using energy from adenosine triphosphate, the myosin heads perform a power stroke, pulling actin filaments toward the center of the sarcomere. As this cycle repeats, the sarcomere shortens, resulting in muscle contraction. When stimulation ceases, calcium is actively transported back into the sarcoplasmic reticulum, cross bridges detach, and the muscle fiber returns to a relaxed state. From a clinical perspective, disruption of any step in this mechanism may impair muscle performance. Calcium imbalances may reduce force generation, ATP depletion contributes to muscle fatigue, and neuromuscular disorders may result in partial or complete paralysis. For NCLEX-style application, learners should recognize that effective muscle contraction depends on intact neural signaling, sufficient energy supply, and proper calcium regulation. Alteration in any of these components may compromise patient mobility, respiratory function, and overall safety. A motor unit consists of a single motor neuron and all the muscle fibers it innervates. Each motor unit functions as a basic control unit that determines how much force a muscle can generate. When a motor neuron sends an impulse, all of the muscle fibers within its motor unit contract simultaneously. This principle, known as all or none response, ensures coordinated and efficient muscle activation. Motor units vary in size depending on their function. Small motor units contain fewer muscle fibers and allow precise, finely controlled movements, such as those required for writing or manipulating small objects. In contrast, large motor units innervate many fibers and generate powerful contractions used in activities such as standing, lifting, and climbing. Muscle force is regulated through a process called motor unit recruitment, which involves activating additional motor units as greater strength is required. This process follows the size principle, in which smaller motor units are activated first, followed by progressively larger units as demand increases. Through graded recruitment, muscles are able to produce smooth, controlled contractions rather than abrupt, uncontrolled movements. This mechanism allows the body to adjust force output based on task requirements. Clinically, disruption of motor unit function may result in weakness, poor coordination, and early fatigue. Nerve injuries, neuromuscular disorders, and age-related changes may impair recruitment patterns and compromise functional performance. For NCLEX-style application, learners should recognize that reduced strength, tremors, or impaired motor fine control often reflect abnormalities in motor unit activation and require thorough neurological and musculoskeletal assessment. Muscle tone refers to the continuous low-level contraction present in skeletal muscles even when the body is at rest. This baseline activity is essential for maintaining body alignment and supporting upright posture. Through sustained muscle tone, postural muscles stabilize the spine, hips, and lower extremities, allowing individuals to sit, stand, and move efficiently. Without adequate tone, joints become less stable and body alignment deteriorates. During movement, muscle tone plays a critical role in maintaining balance and stability. Coordinated activation of surrounding muscles prevent excessive joint motion and support smooth, controlled movement patterns. Regulation of muscle tone is controlled by complex interactions between motor neurons, reflex pathways, and the central nervous system. With continuous input from proprioceptive receptors located in muscles and joints. This feedback system allows the body to make the constant adjustments to posture and position. From a clinical perspective, decreased muscle tone may result in poor posture, joint instability, and increased fall risk, particularly in older adults and neurologically impaired patients. In contrast, excessive muscle tone may lead to stiffness, spasticity, and reduced mobility. For NCLEX-style application, learners should recognize that changes in posture, balance, or muscle stiffness often indicate underlying neuromuscular dysfunction. Early identification of tone abnormalities is essential for preventing injury and promoting safe patient mobility. In this slide, we are examining muscle fatigue and muscle endurance, two key concepts that directly affect patient mobility, safety, and recovery. Understanding fatigue helps nurses recognize early signs of weakness, prevent injury, and plan appropriate care. Muscle fatigue refers to a temporary decline in muscle performance following prolonged or repeated activity. When muscles become fatigued, force production decreases, contraction efficiency declines, movements become slower and weaker, coordinated is reduced. Fatigue most commonly occurs during sustained activity, illness, immobility, or inadequate nutrition. In clinical settings, fatigue is a major contributor to falls and functional decline. Muscle endurance is the ability of a muscle to sustain repeated contractions over time. It reflects how long a patient can maintain posture, walk, perform self-care, participate in therapy, tolerate activity. High endurance supports independence, low endurance increases dependence and risk for complications. Endurance is closely related to fatigue, as fatigue increases and endurance decreases. Energy use in muscle contraction. The central illustration shows how muscles use ATP for contraction. ATP is the immediate energy source for muscle movement. During normal activity, the following occurs. ATP is broken down, energy is released, muscles contract, and with repeated use, ATP stores become depleted, energy supply decreases, contraction weakens, and eventually this leads to fatigue. Several physiological processes contribute to muscle fatigue. ATP depletion. As ATP falls or ATP level falls, muscles cannot maintain strong contractions. This limits endurance and strength. During activity, metabolic byproducts accumulate, including hydrogen ions, phosphate, lactate, and these substances interfere with muscle contraction and increase discomfort. Calcium also is required for muscle contraction. Whenever there's fatigue, calcium release declines. Binding becomes less effective, contraction weakens, and this reduces force output. Fatigue also affects nerve-muscle communication. When signaling becomes impaired, muscle activation slows down, coordination decreases, reflexes weaken, and this eventually increases injury risk. Now, let's connect this to nursing practice. So, when muscle fatigue develops, mobility decreases, transfers becomes unsafe, balance deteriorates, and fall risk increases. Early exhaustion often precedes falls in hospitalized and elderly patients. Chronic illnesses and prolonged bed rest further reduce endurance. Without intervention, weakens progress rapidly. Patients on extended bed rest experience the following: rapid muscle wasting, loss of endurance, reduced balance, increased dependency. This is also known as deconditioning. Preventing deconditioning is a major nursing responsibility. It is also the reason why most hospitalized patients receive physical therapy ordered by the physician. This eventually promotes activity and mobility, preventing deconditioning. Understanding fatigue and endurance guides nursing care. This knowledge supports the following: activity planning, rest scheduling, mobility progression, rehabilitation support, fall prevention, and nurses must assess fatigue before and after activity. Overexertion increases risk. Underactivity leads to deconditioning, and a balanced progression is essential. So in practice, Nurses should do the following: monitor activity tolerance, encourage gradual mobilization, allow adequate rest periods, promote hydration and nutrition, coordinate with therapy services, and these interventions preserve strength and independence. In summation, muscle fatigue and endurance directly influence patient safety, recovery, and quality of life. By recognizing early fatigue and supporting endurance, nurses prevent complications and promote functional independence. In the next section, we will examine how muscle function relates to major muscle groups and clinical assessment. In this slide, we are examining muscle fatigue and muscle endurance, two key concepts that directly affect patient mobility, safety, and recovery. Understanding fatigue helps nurses recognize early signs of weakness, prevent injury, and plan appropriate care. Muscle fatigue refers to a temporary decline in muscle performance following prolonged or repeated activity. When muscles become fatigued, force production decreases, contraction efficiency declines, movements become slower and weaker, coordinated is reduced. Fatigue most commonly occurs during sustained activity, illness, immobility, or inadequate nutrition. In clinical settings, fatigue is a major contributor to falls and functional decline. Muscle endurance is the ability of a muscle to sustain repeated contractions over time. It reflects how long a patient can maintain posture, walk, perform self-care, participate in therapy, tolerate activity. High endurance supports independence, low endurance increases dependence and risk for complications. Endurance is closely related to fatigue, as fatigue increases and endurance decreases. Energy use in muscle contraction. The central illustration shows how muscles use ATP for contraction. ATP is the immediate energy source for muscle movement. During normal activity, the following occurs: ATP is broken down, energy is released, muscles contract, and with repeated use, ATP stores become depleted, energy supply decreases, contraction weakens, and eventually this leads to fatigue. Several physiological processes contribute to muscle fatigue. ATP depletion. As ATP falls or ATP level falls, muscles cannot maintain strong contractions. This limits endurance and strength. During activity, metabolic byproducts accumulate, including hydrogen ions, phosphate, lactate, and these substances interfere with muscle contraction and increase discomfort. Calcium also is required for muscle contraction. Whenever there's fatigue, calcium release declines. Binding becomes less effective, contraction weakens, and this reduces force output. Fatigue also affects nerve-muscle communication. When signaling becomes impaired, muscle activation slows down, coordination decreases, reflexes weaken, and this eventually increases injury risk. Now, let's connect this to nursing practice. So, when muscle fatigue develops, mobility decreases, transfers becomes unsafe, balance deteriorates, and fall risk increases. Early exhaustion often precedes falls in hospitalized and elderly patients. Chronic illnesses and prolonged bed rest further reduce endurance, without intervention weakens progress rapidly. Patients on extended bed rest experience the following: rapid muscle wasting, loss of endurance, reduced balance, increased dependency. This is also known as deconditioning. Preventing deconditioning is a major nursing responsibility. It is also the reason why most hospitalized patients receive physical therapy ordered by the physician. This eventually promotes activity and mobility, preventing deconditioning. Understanding fatigue and endurance guides nursing care. This knowledge supports the following: activity planning, rest scheduling, mobility progression, rehabilitation support, fall prevention, and nurses must assess fatigue before and after activity. Overexertion increases risk. Underactivity leads to deconditioning, and a balanced progression is essential. So, in practice, nurses should do the following: monitor activity tolerance, encourage gradual mobilization, allow adequate rest periods, promote hydration and nutrition, coordinate with therapy services, and these interventions preserve strength and independence. In summation, muscle fatigue and endurance directly influence patient safety, recovery, and quality of life. By recognizing early fatigue and supporting endurance, nurses prevent complications and promote functional independence. In the next section, we will examine how muscle function relates to major muscle groups and clinical assessment. In this slide, we are reviewing the major muscle groups of the human body using anterior and posterior views. These muscles represent the minimum applied anatomy knowledge required for safe nursing practice under NCLEX, BRN, and AACN standards. Some of these muscles require full memorization, while others require familiarity and recognition. We will not separate these for you. All of them must be understood for competent patient care. This slide serves as our primary reference for applied muscular anatomy. These muscles are essential for the following important reasons: physical assessment, mobility assistance, safe transfers, fall prevention, rehabilitation monitoring, and clinical procedures. This requirement is professional and non-negotiable. In the upper body, the deltoid, triceps, biceps, pectoralis major, trapezius, and latissimus dorsi control lifting, pushing, pulling, and positioning. These muscles are used continuously in patient handling and bedside care. Weakness in any of these areas directly compromises patient safety. In the lower body, the quadriceps, hamstrings, gluteal muscles, calves, and tibialis anterior determine the following: standing ability, gait stability, balance, and fall risk. The vastus lateralis and gluteal muscles are also primary intramuscular injection sites. Accurate identification is essential for medication safety. Several muscles highlighted in red represent deep stabilizing muscles. These are deep hidden muscles, includes the following: supraspinatus, infraspinatus, teres minor, subscapularis, rhomboid major, rhomboid minor, levator scapulae, erector spinae. These muscles lie beneath large superficial muscles such as the trapezius, latissimus dorsi, and deltoid. They are not truly superficial. The levator scapulae lies deep along the upper cervical spine and elevates the scapula. The erector spinae forms a deep postural muscle group that stabilizes the entire spine. Together, these muscles control shoulder stability, spinal alignment, and postural endurance. They are commonly involved in chronic pain, weakness, and functional decline. We are using a single diagram to represent both superficial and deep layers for learning efficiently. In clinical practice, these muscles are assessed thorough function rather than appearance. These muscles must be mastered for the following reasons: accurate physical assessment, safe transfers, fall prevention, gait evaluation, and proper injection technique or intramuscular injection technique. Failure to correctly identify muscle landmarks increases the risk of the following: nerve injury, ineffective medication delivery, or ineffective intramuscular medication administration, permanent tissue damage, and worst case scenario, legal liability and overall unsafe patient care. All of these work muscles together to support essential nursing activities. They allow lifting, carrying, repositioning, reaching, ambulation, and sustained posture during care. Muscle weakness in any region compromises patient safety. Now let's go over clinical connections between these muscle groups. Let's start with deltoid. Deltoid weakness limits self-care. Biceps weakness interferes with feeding. Weakness in the triceps area creates unsafe transfers. And quadriceps weakness prevents standing. Gluteal weakness destabilizes gait, and calf weakness impairs walking. The anterior tibial weakness causes foot drop, and the spinal extensor weakness causes poor posture and fatigue. These findings guide nursing assessment and intervention. Again, memorization and recognition of key muscles is not optional, it is a professional responsibility. Accurate identification is for the following reason. As I repeat, medication administration, mobility assistance, positioning, injury prevention, and patient education. For example, incorrect identification of injection sites can cause harmful or permanent harm for a patient. Therefore, this knowledge is directly linked to patient safety and ethical practice. This slide represents your core applied anatomy foundation. These muscles are learned not for memorization alone, but to protect patients, support recovery, and uphold professional standards. In this slide, we are focusing on common muscular and neuromuscular disorders and how they affect patient function and safety. These conditions interfere with normal muscle contraction, coordination, and endurance, and they often lead to reduced independence and increased risk of injury. Understanding these disorders allows nurses to recognize early warning signs and intervene appropriately. First, let's review the major disorders. We have the following. Myasthenia gravis is a condition which neuromuscular transmission is impaired, leading to fluctuating muscle weakness. Patients often experience drooping eyelids, facial weakness, and fatigue that worsens with activity. Next, we have muscular dystrophy. It is a group of genetic disorders characterized by progressive muscle degeneration. Over time, patients develop weakness, contractures, and limited mobility. Amyotrophic lateral sclerosis, or ALS, is a neurodegenerative disorder that affects motor neurons. It leads to progressive paralysis and eventually respiratory failure. Next, we have rhabdomyolysis. Occurs when muscle tissue breaks down and releases myoglobin into bloodstream. This can damage the kidneys and become life-threatening. A common clinical condition among patients overdosing in methamphetamines, and a medical emergency encountered in the emergency department. Lastly, we have disuse atrophy. It develops when muscles are not used for extended periods, such as during prolonged bed rest or immobilization. These disorders commonly produce similar function limitations. Patients may experience progressive weakness, they may have reduced endurance and fatigue easily, coordination and balance may be impaired, mobility often decreases, and as a result, patients may lose independence in daily activities. These changes significantly increase fall risk and care needs. Now let's connect these conditions to real patient care. In myasthenia gravis, patients show fluctuating weakness and ptosis that worsens later in the day. In muscular dystrophy, patients develop delayed mobility and joint contractures. In ALS, patients gradually lose voluntary muscle control and respiratory function. In rhabdomyolysis, patients may have muscle pain, dark-colored urine, and signs of kidney injury. In disuse atrophy, patients are at higher risk for falls and pressure injuries. These findings guide nursing monitoring and interventions. As nurses, your role is to detect early signs of deterioration and protect patient safety. This includes the following: monitoring muscle strength and endurance, assessing gait and balance, observing respiratory effort, tracking or monitoring urine output in suspected rhabdomyolysis, promoting early mobilization when appropriate, educating patients and families. Early recognition can prevent complications and improve outcomes. Muscle disorders affect every aspect of patient care, from mobility and hygiene to medication administration and discharge planning. They influence staffing needs, equipment use, and interdisciplinary referrals. Understanding these conditions allow nurses to elaborate effectively with physicians, therapists, and rehabilitation teams. This slide emphasizes that muscular disorders are not isolated diagnoses. They are conditions that directly affect safety, independence, and quality of life. By understanding their mechanisms and clinical presentation, nurses can provide proactive patient-centered care. In the next section, we will summarize key concepts and integrate this knowledge into clinical practice. This slide summarizes the major concepts of Chapter 7 and provides professional closure. Skeletal muscles enable movement, posture, and stability. And at the microscopic level, sarcomeres generate force through coordinated interaction between actin and myosin, regulated by the calcium and ATP. Motor units control the strength and precision of contraction. Muscle tone supports balance, while fatigue limits performance. Major muscle groups play a critical role in patient mobility, safe transfers, and medication administration. Muscular disorders impair independence and increase clinical risk. So in practice, nurses apply this knowledge through accurate assessment, fall prevention, early mobilization, and interdisciplinary collaboration. As you prepare for assessment, review and master all chapter concepts. Complete all examinations with honesty and discipline. Academic integrity reflects professional responsibility. Remember, in healthcare, knowledge is not optional and errors carry real-life consequences. Thank you again for completing this chapter, or Chapter 7. Your dedication to learning strengthens patient safety and professional practice. In the next chapter, we will examine how the other body systems support muscular function and endurance.